Put the slide.
Okay, sir. Is it visible, sir?
Yeah. Take that picture of that unknown user away. You can start. Yeah.
Okay, sir.
Yes.
Miss Pragya Nandini Hazarika, 6-year-old girl, resident of Assam, informant being mother and reliable. Chief presented with chief complaints of fever for 2 days 1 month back and cough and cold for 2 days 1 month back. Patient was apparently all right 1 month back. To start with, she developed multiple paroxysms of high-grade fever, not relieving with oral antipyretics. It was followed by non-productive cough and runny nose, for which she went to local hospital and evaluated to have heart disease and referred to higher center for further management. She had history of multiple episodes of respiratory tract infection associated with fever, not requiring any hospitalization and subsiding with oral antipyretics and antibiotics in the past. No history of Socrates cycle 4-8 sweating or any growth retardation during infancy. No history of seizures. No history of joint pain, swelling of major joints or rash. Antenatal history, she was born out of non-consanguineous marriage with an uneventful antenatal history. Natal history, fast order term elective LSCS delivery with no significant event. Postnatal history, cried immediately after birth, no history of admission to NICU. Immunization is appropriate as per age and national immunization schedule. No history of developmental delay. Personal history, she is on mixed diet with normal bowel and bladder habit. Family history, grandmother had ASD, operated for the same, and grandfather has rhythm issue for which PPI was inserted. Uh, Treatment history, she was on tablet furosemide 20 mg and tablets Paronate 25 mg, half tablet BD for last 1 month. Summary, a 6-year-old female born out of non-consanguineous marriage presented with complaints of fever, cough, cold for 2 days 1 month back, evaluated for heart disease and referred here with past history of multiple episode of respiratory tract infection with uneventful antenatal, natal and postnatal history.
Good. That is nice. Crisp presentation. And what do you make out of this history?
This history, I think it is a cyanotic congenital heart disease with left to right shunt.
Uh, More than that, you should say increased pulmonary flow situation. Okay.
Yes, yes,
So repeated respiratory infection is a feature of increased pulmonary flow situation. So that rules out most of the cyanotic, especially the low pulmonary flow situation. So you will nose down to left to right shunts, that is ASD, VSD, or a PDA,
period.
right?
Yes.
Okay, okay, go ahead.
On general examination, child is playful, cooperative, thin built, weight
Mm.
of 18.9 kg, height of 125 centimeter, which is appropriate for her age, BMI of 12.10 kg per meter square, vitals temperature 97.8 degree Fahrenheit, pulse rate 100 beats per minute, regular, normal volume, no radial or radiofemoral delay, all peripheral pulses felt. Blood pressure 98 by 60 millimeters of mercury, right arm supine position, all four limb blood pressure was measured and there is no variability. Respiratory rate 18 chest raise per minute, saturation 97% on room air. JVP is not raised, no pallor, icterus, clubbing, cyanosis, generalized lymphadenopathy or pedal edema. Head to toe examination is normal. Cardiovascular system examination. On inspection, chest wall shape symmetry appears to be normal. No precordial bulge. Trachea appears to be in midline. Apical impulse is visible lateral to mid-clavicular line. Visible pulsation present over lateral to left sternal border. No dilated veins present seen or no other gestual deformity. On palpation, apex is confirmed to be on left fifth intercostal space, 1.5 centimeter lateral to midclavicular line. Grade 1 parasternal hip present on left sternal border. Palpable P2 present over pulmonary area. No other thrill felt. On auscultation, S1 appears to be normal. S2 wide fixed split is hard. Loud P2 present. Grade 3 by 6 ejection systolic murmur hard in pulmonary area and a soft mid diastolic murmur hard on left lower sternal border in fourth intercostal space. Respiratory system examination, bilateral equal normal vesicular breath sounds present, no added sounds present. Parabdominal finding soft, no organomegaly, bile sounds present. CNS examination, no focal neurological deficit. Uh, Provisional diagnosis 6-year-old girl child with acyanotic congenital heart disease with large left to right shunt in pre-tricuspid label, most likely atrial septal defect with features of pulmonary arterial hypertension without any features of infective endocarditis, congestive cardiac failure, or thromboembolic event in sinus rhythm.
Very good. Excellent presentation. After a long time, we have had a very smooth presentation, and keep it up. This is how a presentation in the exam should go. Because see, you did not waste much time. You went through the whole thing in a systematic manner, and now you have enough time for discussion of the case. Very good.
Thank you, sir.
The only thing is, everybody says this forehead sweating. Sign of that in a if you refer any pediatric textbook, there are 100 causes of forehead sweating. That's not the indication of left heart failure. You'd say feeding difficulties. Once you say feeding difficulties, you say the suck less. And most important thing, they present with tachypnea and tachycardia. So these are
Yes.
the important things. And the thing in any left to right shunt is a failure to thrive. What do you mean by failure to thrive? the height,
Hello.
whatever the length when the child is lying, the baby is lying, and the weight is not as it should be for that particular age. And in most of these congenital heart diseases, it's the weight that is affected more than the. That's one thing. The other thing, what's the importance of grandmother having ASD? Any connection with that? How many percentage of patients with congenital heart disease, if sibling has got similar heart disease, how many percentage will have heart disease of same type?
Sibling.
Any senior, final year, this is a question sometimes the exam is. The usual answer is about 3%. It's especially in VSD, but in ASD also. If one sibling had same type of heart disease, the second sibling, the possibility is 3%. If two siblings had, the possibility goes up 8 to 10%. If the mother had ASD, the possibility is 3%. If the father has much less, it's about 1%. Actually, if you read Mayung Park, the textbook, a lot of people follow, they're given a chart of what is the chances of a sibling having same type of heart disease. Okay, so in this case, is a repeated respiratory infection, but no other signs of failure. Can proceed.
So I'd like to reiterate what Sir said. You know, in a child of 6 years, you don't talk about feeding difficulties.
Yeah.
It's only in an infant between 6 months to 1 year.
Yeah.
Less than after 1 year, you don't talk about feeding difficulties. And then you said development was normal, but actually you should talk about failure to thrive, as he very rightly said. The next thing that I want to know is this child is a 6-year-old child, and according to your history, this child seems to be in going into failure, becomes symptomatic very early, and patient is on diuretics. Okay.
Yes, sir. Yes, sir.
So this is a little unusual in a ASD, unless it's a very, very large ASD. Okay. And then a very large ASD, you have to look for associated defects, maybe a common atrium, whether there's an AV canal defect and other things you have to look for when you're doing the investigations. Okay.
Yes.
So an ASD generally does not present with gross failure in such an early age. So you must, so that itself must alert you that you have to look for other things as well present, if there are any in your investigation. Okay.
Yes, sir.
This is actually for the final years. All right. So you must think.
I don't think the child is in failure. I now heard, what did the Indian pediatric cardiologist say about the presentation of ASD in the first year? This is extremely rare, less than 10% of the patients with an isolated ASD present in the first year. In that case, you must exclude two things, they say. One is whether you are missing a total anomalous pulmonary venous connection, especially the cardiac type, which may be missed. And number two, they say you must exclude a left ventricular inflow obstruction, any cause for a mitral valve obstruction. What is the mitral valve obstruction due to the hemodynamics of ASD?
Left mitral valve defect will be present.
Louder, I can't hear. Yeah.
Left mitral valve defect will be present associated with ASD.
Now, how the hemodynamic changes if there is a left ventricular inflow tract obstruction in ASD. Adult, later child, we say Luton Bass. I'm not saying that it's a congenital. The most important thing is the flow is torrential because there is an obstruction to the mitral valve. The left-right shunt is torrential. The other thing is, because it's a large ASD, there's emptying from the left atrium to the right atrium. The pressure gradient across the mitral valve becomes very insignificant, much less. So much so, you underestimate the mitral stenosis when there's an ASD. Okay.
So the only thing that does not fit in your entire thing is the, I don't know why they have started here on furosemide and spironolactone. I mean, two diuretics together in a 6-year-old child is not, does not sound good. I don't know why.
Say right heart failure or left heart failure? Congestive heart failure. I never heard of ASD producing a left heart failure. And there's no symptoms of left heart failure.
Yeah.
Sir.
And there's no sign of a right heart failure.
Yes, sir.
Okay.
So anyway.
Try and find out what the reasons.
Okay, yeah.
Discuss with your consultant whose case is this, and then check all these things. Okay.
Yes, sir. This actually medication started from that outside hospital.
I know. That is
Hospital-
the reason why they would have, somebody would have started it for what reason, whether it was indicated or whether it was a mistake. You have to know. You have to learn to interpret that as well. Okay.
Yes, sir. Yes, sir.
Okay. What investigations have you done?
I'd like to proceed with chest X-ray, ECG, and echo Doppler.
Good.
This is a well exposed, well centralized PA view chest X-ray from central to peripheral manner. Tachia appears to be central in position. CT ratio of 0.6 with aortic knuckle not prominent, with pulmonary bay full, and apex wing equivocal type of apex, and in situs. And there is increased pulmonary, there is plethora and bilateral CP angle free with no associated chest wall deformity.
This is a digital X-ray, so it is very difficult to comment on the lung fields and especially about plethora. But whatever you can see is there are some increased bronchovascular markings. So that may be a clue. In digital X-rays, nowadays everybody does digital X-rays. You can't comment on the pulmonary vasculature or especially the pulmonary blood flow situation. Okay.
Okay, sir.
All right. So this shows that there is increased pulmonary flow because the pulmonary bay is bulging out, the straightening of the left valve.
Yes, sir.
And there is increased bronchovascular markings. So can you tell us whether this is an intracardiac shunt or an extracardiac shunt?
It is a
what are the intracardiac shunts and what are the extracardiac shunts, and how do you differentiate on the X-ray?
intracardiac shunt, ASD, VSD,
Okay.
extracardiac PDA.
Good. Now, how do you differentiate that on the X-ray? Intracardiac shunts, the aorta will be small. In extracardiac shunts, the aorta will be large or prominent. Okay?
Yes, sir.
That is the first differentiation. So if you have a prominent aortic shadow and there is increased plethora, you must think of an extracardiac shunt like a PDA, AP window, and things like that. Intracardiac would be AST versus VST. How do you differentiate the two?
AST in X-ray, right border of the heart will be enlarged. VSD left side of heart, LA and LV enlarged. Hypertrophy or enlargement will be there, LA. But in AST, LA enlargement won't be there. RA, RV dilatation usually seen.
RV. In ASD, there will be RV enlargement, whereas in a VSD, it would be basically LV or biventricular in a long-standing VSD. Okay, so that is how you get a clue on the X-ray itself whether there is a shunt, whether there is a left this thing, whether it's intracardiac, extracardiac, whether it's ASD or VSD. Okay.
Yes, sir.
Okay. Next.
This is a 12-lead standardized ECG, rate of 100 beats per minute, sinus rhythm, axis of 90 degree, and there is no evidence of RALA enlargement, and there is in V2 there is some RSR pattern, and there is lead 2, 3 and AVF. There is notching of the QRS complex.
When you say 90 degrees, what have you ruled out?
90 degree axis, normal axis. There is no right axis deviation. So
what have you ruled out?
Right, RVH.
No. Among the ASDs, you're talking about ASDs.
Ostium primum.
Good. Very good.
That I have ruled out.
Ostium primum usually will be associated with an AV canal defect, and they usually will have a left axis deviation, right?
Yes, sir. Yes, sir.
Okay. And then you also mentioned about RSR pattern. That is good. Then usually you will see that in an ASD.
Yes, sir.
All right. Next.
What is the notching of RV in inferior leads?
Notching of RV in inferior leads, that indicates that that is.
What is sign? What is it called actually?
Crockett sign.
Yeah.
What sign?
Crockett sign.
It's pronounced as crossetage. Anyway,
Crossetage.
it depends. A lot of people pronounce it difficulty. It's like a crochet. You're knitting things. So it's a crossetage sign where there's a notching of the R wave in inferior leads. Lead 2, 3 AVF. In this AVF is very clearly seen. There is a crossetage sign. Okay. So the classical signs, ECG, SDR, right atrial enlargement,
Yes,
right axis deviation, maybe between 90 and 120, and in primum ASD, left axis deviation, right atrial enlargement, RSR pattern, and the crosscut sign. Okay. So this fits in with okay.
this is the 2D echo Doppler study showing situs of solidus of the abdominal organ, situs solida to levocardia with normal systemic and pulmonary venous drainage with atrioventricular connection and ventricular atrial connection concordant with normal left atrial and left ventricular size with dilated right atrium and right ventricle, and interatrial septum being suggestive of large ostium secundum AST 31 into 30 millimeter with left to right shunt, small IVC rim, deficient aortic and posterior rim, interventricular septum being intact, mitral valve and tricuspid annulus 28 mm and 30 mm respectively, aortic valve and pulmonary valve 15 mm and 23 mm respectively with tri-leaflet aortic valve, and pulmonary artery being confluent branch PA with RPA LPA size 14 mm, left aortic arch with absent PDA and normal coronaries. And Doppler measurement suggestive of grade 2 TR with peak-to-peak gradient 30 millimeters of mercury, mitral trivial MR, aortic no air, pulmonary mild PR with LV ejection fraction 60%.
Okay.
Or the PA pressure there.
PA pressure, they have mentioned mild pH, but not exact how much is the PA pressure, they have not mentioned.
So there is only an ostium secundum ASD, no associated abnormalities.
Yes, sir.
Except for a small trivial MR. Okay.
Yes, sir. And grade 2 TR.
Okay, good. Now let us go to the final years. Who are all there? Logeshwaran I had seen. Logeshwaran and Amulya. Amulya, what will you do with this patient?
Morning, sir.
Morning. Does this patient require operation? If so, why?
Yes.
If so, why? Second, when will you do the operation? And what operation you will do and how you will do? And what are the problems that you can anticipate on the table? These are the questions that you will be asked to you.
Yes. An
So
ostium secundum. Sorry, sir. Ostium secundum ASD with the size of 3 centimeters, which is large one when patient is symptomatic and already 6 years old. Symptomatic patient with a large left-right shunt. It's indication in the preschool age is indicated for closure.
So suppose it's a large ASD of 3 centimeters, good left to right shunt. There's no symptoms because many often the ASD is asymptomatic. You will not operate it.
No, sir. A large ostium secundum ASD should be operated when diagnosed.
Operated. If the shunt is more than 1.5:1 in
Yes.
ASD, whether symptomatic or not, it has to be operated. The only question is whether you are going to do a cath closure, device closure, or a surgery. That's the most important thing you have to decide because these days, in that case, what are the indications of doing a device closure in an ASD?
Device closure is feasible with the sizes of ASD being in the range of 2 mm to 30 mm, and if there is any the rim of tissue must be at least more than 4 mm away from the septal.
No, that's not very. That's not the. In an ostium secundum, should have. Some people say 5 millimeters, some they say 4 millimeter margins.
Yes.
All around. That's one. Number two, what's the weight recommended?
More than 8 kgs for device closures, because the for cath, if you do lesser than that, the femoral vessels will be at risk.
No. This is usually done to the femoral vein. That's all that. That's why I said you don't read that. The recommendation is the child should be more than 15 kilograms. The reason is mainly not because of the accident, mainly because the emplaster device is a very massive one, large one, you know. In a small child less than 15 kilogram, it's not advisable to put a emplaster device. There's another device called the CardioSeal, but not much used. So it's in that recommendation, they say a BSD can be a device closer than in a kid less than 8 kilogram. But ASD, because the pure size of the huge device, they say 15 kilograms. So when they say that, you should accept that. And the margins. And there is no other valve disease. Generally, you can do a device.
The important thing is the IVC rim. If the IVC rim is deficient, you cannot do a device closure because that will interfere with the tricuspid valve function.
Yes.
That's why all around should have a margin of 4 millimeter. Used to be 5 millimeter, now cardiologists we are doing this 4 millimeter. So it should say all around. Should be margin. Otherwise, you cannot seat the device properly and then maybe leak. They may even lead to a shunt from the IVC to the left atrium. The device itself may get displaced if there's not proper seating. In this case, in the echo, did they mention the margins all around? Okay.
So you will do a device closure or a surgical closure?
Surgical closures.
Okay. If
That's
you're doing
good.
a surgical closure, what will you do?
Patch closure of the atrial septal defect.
What will you use for a patch?
Either a treated autologous pericardium or a Dacron patch with a smooth surface facing LA side.
Okay. Now, why do you want to do a treated patch? What are the pros and cons of a treated patch versus an untreated patch? You should
For
know.
the decellularization of the patch and scaffolding of the patch to maintain the integrity so that the patch doesn't disintegrate or aneurysm in the aneurysm should not occur in the future and that patch remains intact. However, treating with glutaraldehyde has disadvantage of calcification.
Okay, but people used to do direct pericardial autologous pericardial patch closure earlier. See, the main thing is in a treated patch, the handling of the patch is much easier so that it is a little more stiffer so that you can sew it well. All right.
Yes.
And in an untreated patch, the only thing the untreated patch can shrink a bit as the child grows, and because of fibrosis and as well as the heart size increasing. So that is one of the objections to plain this thing. And also handling is because it is floppy. Suturing, somebody has to hold the other edge, and then you need a good assistant to complete the patch. So those are the things that are advocated for autologous patch, whereas a treated patch is much easier to handle. How do you do a treated patch? What do you do?
We use 0.6% glutaraldehyde At least for 20 seconds, it is treated.
20
And
seconds. I thought it was much more. 20 seconds.
2 minutes, it becomes harder, so very hard.
20 seconds and 2 minutes is a long difference, madam.
They just what I've seen here practicing, they don't. It is very less than 1 minute, so because more than that, it becomes very hard to handle.
If 1 minute or slightly, yeah, 1 minute is reasonable. And then what do you do?
Sorry, sir.
You dip the patch pericardium in glutaraldehyde for 1 minute. And then after that, what do you do?
After that, in the saline, it is washed and then
For
used.
how long? It has to be washed minimum 10 minutes. Okay, in saline.
Yes, sir.
Otherwise, you will have some amount of residual glutaraldehyde, which can give rise to problems later on. But like calcification, as you said, right?
Yes.
So, what other materials can be used?
A single valor or a double valor Dacron patch.
Velour. It's not Valor. Valor. VELOUR.
Oh, you. Yes.
Not Velour. Velour. All right. What is
Okay.
this Velour? What is this Velour business? And why is it done?
To prevent hemolysis, sir, on the LA side, it should be smooth surface.
No.
You're contradicting yourself. A double valor you cannot use because it's not smooth on the left side, So if you use it as a single valor or ordinary Dacron patch.
Velour means that they form loops
Yeah.
in the surface of the patch. Okay, the Dacron forms loops, multiple loops, like like velvety feel you will get if you have felt a velour patch, and that is made to allow fixation of the endothelium onto the patch. So that is why velour is done. It could be single velour or double velour. All right.
Yes, sir.
Yeah. So you must know what is the thing. And then of course in NH they used to use what was called Savage patch. Savage is a trade name. Savage is not the material. Savage is a trade name, and it is again a Dacron patch with markings so that you could cut the patch to size, whichever size you wanted. Okay.
Yes.
Yeah. And
Another
then
thing the examiners ask you, you're a young surgeon. As soon as you open the sternum, what are the things you look for before operating on a ASD or any other congenital heart disease?
Look for innominate vein presence, sir.
Yeah.
okay. Usually they are present.
First thing, in children there may be large thymus. So
Yes.
will you exercise the whole thymus or you part of the thymus?
Subthymic.
Sometimes you exercise one half of the thymus, then you look for the innominate vein, whether it is a normal size or not. If it is small size, what
You should look for it after opening the pericardium. Look for left SVC.
Good.
How do you look for that?
I mean, behind the LA, lifting the heart towards.
Yeah, you have to lift the heart and see the whole of the posterior part of the left ventricle, then the left atrium. Then where will you see the left superior vena cava?
After lifting it up, the drainage usually is into the coronary sinus, so it goes behind.
It's actually goes obliquely from about the coronary sinus. supposed to be in the oblique vein of Mars. That's one thing. Look for SVC. And we have described many times how to manage an left superior vein cavity. The other thing what you look for after opening the pericardium, before you tape the superior vena cava.
You look for the size of aorta, RA and RV.
No. You don't open the pericardium. What you look for on the superior vena cava? Before you tape.
Any partial anomalous drainage?
Yes, of course, the partial anomalous carbon the vein is draining in the superior vena cava. So two things you note: the size of the superior vena cava in its upper part. If it is small, you must always suspect a left superior vena cava. But lower down near the atrial junction, if it is bulging, you must always suspect that there is a anomalous problem. So you should be careful. Should see that you shift the pericardium to the right side and see if there's any pulmonary vein joining the mouth of the superior vena cava, or even higher. Then only you tape the. Very important. The other thing is sometimes you look for the thrill of a PDA also, because you don't want to get caught with a PDA, even though echo they have said there's no PDA. So these are all the things you look for before you do your cannulation and other things. Okay. And proceed, the steps of surgery. What cannulation you are going to do?
After opening the pericardium, aortic purse strings, and ask the anesthetist to give heparin 4 milligram per kg body weight. Once above 300, you can cannulate and wait the ACT to go above more than 480 to go on bypass. It's a aortic and bicaval cannulation. And after that, the antegrade purse strings for the cardioplegia. Once it is more than 480 ACT, to go on CPB with head and low to maintain flows of cardiac index more than 2.2. Then cooling in case of ASD would be just drifting, mild hypothermia up to 34, or even a normothermia.
Suppose there is a left superior vena cava. Going to
you can either cannulate left SVC, or after opening the RA, it can be the pump sucker can be put into a coronary sinus. Usually, here the practice is to cannulate the left SVCs.
Depending on the size, don't commit yourself to cannulate all the time. Okay.
Yes, sir.
Depending on the size of the left SVC, if you can put a sucker through the coronary sinus, it's good enough. Okay, basically you want to keep the operating field dry.
see, in olden times when there was no Pacifico right angle cannula was there. There's no chance of directly cannulating the left superior vena cava with straight cannula. That time, the classical procedure, if there is a large SVC, left SVC, is to cannulate it through the coronary sinus. Unless it's a small left SVC, the coronary sucker is not a good thing. Sucks too much, produces trauma of the red blood cells. So if it is very small one, if it is before Pacifico cannula came, what we used to do, we used to tape the left superior vena cava after going on bypass, you snare it when you open the right atrium, then through the coronary sinus, you pass the cannula. When it reaches near the snare, you release the snare, pass it beyond and snare it back. In the classical data. Previously, they used to say if it's a small left SVC, you can clamp it and take the stump pressure. Stump pressure means the pressure above that. But that's not done nowadays. Nobody does the stump pressure and decide to calibrate. So nowadays, classically, if it's fairly large or medium size, to better calibrate directly with a Pacifico cannula. That should be your answer. That's
Okay.
what routinely done in Narayanak there.
Yes.
You can say sucker, but I don't like that actually, putting a sucker and that. So if it's a large one, you have a direct candidate.
So as soon as you open the chest, you look for the SVC and then you have to alert your perfusionist to give you an extra line.
Yes, sir.
Okay, that is important. Later on, you can just say, oh, I will cannulate, and then he has to make alterations in the circuit. Okay.
Yes,
So
sir.
that is the importance of looking at the heart.
Yes, sir.
All right, you drift to 234, then you will do. What do you do as soon as you open the RA?
Before opening, to snare both the KV so that the air doesn't enter and it is a bloodless field. Then after RA is opened through an incision starting from the base of the appendage parallel to the AV groove about 1.5 centimeter above it towards the IVC. Once opened, take stay sutures and examine for the borders of the